Hello, my name is Noemie Kloucek, and I'm a Manhattan team lead here at New York Start region for Triborough. Today, I will be discussing our poster findings looking at the implications of psychiatric diagnosis and polypharmacy for frequent start crisis line utilization. The aim of our study was to conduct a retrospective review of data for individuals who had multiple crisis calls over a 6-month period in order to explore possible influences and patterns. We hypothesized that individuals who were using the crisis line frequently would have multiple antipsychotic medications and multiple psychotic disorder diagnoses. For the purpose of this study, we determined that individuals who were using the crisis line frequently would have 7 or more calls during the 6-month period. Our sample size included 11 individuals with an average age of 31. Some key findings were that 81% of our sample had GI problems and 81% had a history of institutional care. We also found that 55% of the sample had sleep problems, while 45% experienced seizures. Overall, 64% of our sample were diagnosed with ASD, and 50% of our sample were prescribed 4 or more psychotropic medications. 10 out of the 11 had 1 antipsychotic, and 3 out of the 11 had 2. There were about 3.3 medical diagnoses per person, which is a high rate for a sample with an average age of 31. We included a case example of a 35-year-old male with 5 psychotic disorder diagnoses and 6 psychotropic medications that uses the crisis line frequently in order to outline a profile that we found among the 11. Overall, we did see a high number of psychiatric diagnoses, presence of ASD, and a high number of medications were seen in all individuals who were using the crisis line frequently. We also found polypharmacy in the entire sample, and sleep disorder and GI were the most common medical conditions noted in SIRS. We were surprised to find a very low rate of anxiety and trauma diagnoses in our sample, yet a high rate of disruptive impulse control disorder and ADHD. This indicates a need for diagnostic clarification to appropriately support individuals without the need of emergency interventions. So some of the next steps we want to take after conducting this study is to involve the medical director and clinical director during the initial work by presenting cases who had similar profiles, such as our case example, and the rest of the sample. Given that psychiatric diagnostic confusion and use of polypharmacy likely adds risk for needing crisis interventions, we recently also began increased clinical consultations at intake in order to capture some of our concerns. Thank you for listening to this presentation, and please look to our poster in order to get more detailed findings. Thank you.